अच्छा कोई कैसे join
Dr. TahirKheli, can you hear us?
Yeah, we care about appendage. Right. Yeah, right there. These ones. So let's start. We're going to start with this. Yes, yes. We just want to show them the measurements and how we measure. Yeah, that's it.
Dr. TahirKheli?
Hi there. Can you hear me?
Yes, we can hear you. Yep, but we can't see you.
Okay, so
Please turn on your camera,
who is
please.
on the panel? Can you introduce us? No, the sound will all connect. He's trying to connect. Okay, can you see us?
Yes, we can see you. So just let me introduce you to the audience. I don't think you need any intro because everybody in Pakistan is very aware of you and very thankful to you for the time that you take to educate us. So just on behalf of all the audience, we would like to thank you once again for taking time out as well as resources that you have put into organizing this case. So please go ahead and tell us about the case.
Is my microphone on, right?
Okay, so do you hear me all right?
Yeah, we can hear you and we can see you as well. Hi, it's Ali Raza
Okay.
here.
All right, so sorry, just like whenever we do major stuff, there's always a small little detail that we can't think of. So our patient started having diarrhea this morning. And so he just would not get on the transport down here. So we're slightly delayed. We apologize for that. I'm going to introduce you my protege, Dr. Syed Haider Ali. Haider, I have a long history with him. He was a spry young individual wanting to work in the US, and he came and did observership with me back in 2007, 2008. Of course, working a couple, 3 months with us, we infected him with the interventional cardiology virus that has not relieved him since. And so he went to telemedicine, and I think we tried to talk to his program director and got him into cardiology. So once he graduated, the first thing we did is we brought him back and hired him with us. He is brilliant. He does TAVRs and is very good in interventional cardiology and CTO. So he'll be doing the CTO case with me tomorrow also. He's going to, so he does all the T's for our mitral clips and other structural also. I'm going to have him kind of give you the detail of the patient and also go over the CT scan and the TEs. And then what I want to do is I want to start the case live. So we've not gotten into the vein here. We'll go that in front of you. I want to show you how we do the ultrasound access. We'll do the transeptal in front of you. We have some new devices for transeptal. We'll do that under transesophageal echocardiogram. I know you had earlier talks where the transeptal catheterization was discussed and the CTA was discussed. So hopefully we can do all of that and talk about left atrial appendage occlusion and the need for that in Pakistan. Bashir, I've been asking him to let me do this for the last 2-3 years, and he says there's no need for that in Pakistan. And I have probably the opposite view. I think this LA occlusion should be done in Pakistan because you do this once and you now protected the patient for the rest of the life. For the best of the papers, you know that when you're on Coumadin, you are on adequate INR for about 50% of the times. If you look at the data of patients who are actually on Eliquis or Abixapan, as you would say, or the other NOACs, when you look at them in registries of on treatment, So you identify atrial fibrillation and you give them anticoagulation. When you look at the registries, you will find that about 50% of the patients actually stay in it for a long-term basis. For some reason or the other, they stop doing that. And this is in the US. So you can only imagine how it might be in Pakistan, where the follow-up may not be that close. So I think the left atrial appendage occlusion is a simple, straightforward procedure. Can be complicated, but most of the times with you guys who are doing a lot of mitral valve balloon valvoplasty and stuff, you are used to being in the left atrium. You should be able to do it easily. So I'm over to Heather.
Assalamu alaikum, everyone. I hope you can hear me. So today we're going to present this case of Watchman device implantation left atrial appendage. This patient is 73 years old gentleman who was referred to us for evaluation of left atrial appendage occlusion. He has a history of atrial fibrillation diagnosed in 2019, has a CHADS2-VASc score of 3, so high risk of stroke, has blood score of 3 as well. He was treated with Xarelto initially, and then he developed low hemoglobin. Workup showed dark TARIS2s, velinas, bleed. So could not take the anticoagulation, and decision was made to implant the Watchman device. So I'm gonna show you, go through the CT images first, and then TE images. So here's this is
Hang on, let's just introduce Derek. Derek Cummings is our rep. One of the things that you already know in Pakistan, most of our structural heart is really dependent on our reps from the company. They really help us out, and they a lot of times have a lot more experience than we do. So we really lean on them and their experience. So Derek is my clinical rep, actually. And so we had a 3D rendition of the CTA. We do it at our place, we do it our own, and then these guys will actually put it on 3D Mencio and actually give us a 3D, even a better rendition. So.
All right, so let's focus on there. And so these are the CT axial images for left atrial appendage, and that shows the audio portal view. So go down. So we can see this is 3D image of the audio portal view. This looks like, if you see the body of the appendage and the angle with the ostium, this is less than 100 degrees, so that makes it chicken wing appearance. So as we know that there are 3 kind of appendages that we care about when we're implanting these devices: chicken wing, broccoli, and windsock. So chicken wing being the most common and technically slightly difficult because of the sharp angle and sharp bend. The operator has to manipulate the catheter to get into the depth of the dominant lobe. So that's slightly technically challenging. And at the same time, this is the most common type of appendage you'll see. About 50% of the appendages are chicken wing appearance. Okay, so let's size it.
Can I ask a question as well?
There are 2 things. We look at the CT, the ostium, and then the landing zone. We don't want to miss any micro lobes. And here is another view I'll show you.
Okay.
So this is, you can see the circumflex coming around, and you can see how the proximity of this artery to the left atrial appendage. And this is the long axis view right there. And this is the ostium. So ostium, we get the measurement, and on the left-hand side of the screen, there's the maximum diameter and the minimum diameter. Sometimes there is a common question that CT or TE images and the measurements do not correlate. So in that case, we go with the largest diameter, and we do a live TE, and we check the volume status, make sure patient is not dehydrated, and then we can resize the device while patient is on the table. Most of the measurements we get, they overlap between 2 different kind of device sizes. So let's say if this is 23 millimeter maximum diameter, and I'll show you the algorithm right here. So on this chart, you can see 23 millimeter falls right here, and then it overlaps with 27 millimeter device and 31 millimeter device. So now that's a good discussion, and Dr. TahirKheli is going to do angiogram with a pigtail catheter in the appendage and further decide which size is the best for this patient. So we can move to the TE images now.
Yes.
So was this patient having Like AF or?
So that's our TE. On the table TE we did, and this is 0 degrees. You can see no thrombus in there. If you have a question about whether there's a thrombus, sometimes there are microlobes and we are not sure if there's thrombus or no, so we can correlate with CT imaging. CT with the arterial phase and delayed phase combined has 100% accuracy about ruling out thrombus. So let's go to next and show them the measurements. So you recognize the circumflex right there, and that's where you start your measurement. So this is 0 degrees. You go straight across to the lateral aspect of the appendage, and then this diameter over here is 2.6 centimeters, and then you get the depth right there in the center, go all the way down to the bottom of the dominant lobe. And this is about, so this is 1.8 into 2.6 centimeters. Go next, please. And so 4 views on T, 0 degrees, 45 degrees, 90 degrees, and 135 degrees. All the measurements are different. It's a very complex structure. That's why we need T, we need CT, we need angiogram, and then we make a decision about the sizing. So this is 45 degrees. Again, same, you recognize where the circumflex artery is. You go straight across to the lateral side of the appendage. And right here, the measurements are 2.1. And then 2.04 centimeters. So again, different than the 0 degrees. So go next, please. And this is our 90-degree view. And you can see you can see the chicken wing appearance. It goes down and then moves to the medial side. That's a sharp angle that makes the procedure technically a little bit challenging. So measurements here are 1.2 centimeter and 1.72 centimeter. And now the most important view is 135 degrees. Go next, please. This is 135 degrees. Appendage looks wider in this view. It gives you good diameters, and this corresponds to audiocaudal view on the angiogram. Measurements here 1.7 centimeters and 2.28 centimeters. So keep that in mind, and then we'll correlate with the angiogram as well.
Okay, so before we move forward, I just need to introduce the rest of my team. So again, the structural heart we've talked about before is an amazing collaborative effort. So it involves CT surgeons, it involves anesthesiologists, it involves structural imaging people, and more importantly, and the most importantly, are our nurses and scrub techs who actually do the real work. So Monica is our ultrasonographer. She's the head of our department, and she's here with us. Dr. Mark Lau is our anesthesiologist. We're extremely lucky to have some amazing anesthesiologists. Obviously, this is the heart hospital, so all of our anesthesiologists are trained to do TEs and have cardiothoracic, most of them have cardiothoracic fellowships. Dr. Lau has been doing this for about 2 months or so with me. I'm just messing with you guys. Dr. Lau and I have been working together for over 20 years now. And he worked with me in the previous hospital, and then when we made this hospital, and moved here, he's nice enough to move us with us over here. So normally we have one of our anesthesiologists man the TE during a Watchman device. We don't have a specific structural imaging person. We're obviously lucky to have Heather today, so he will help us too. Over there are our scrub techs.
He's just getting into the actual,
Sarah is our scrub. She's an RT and does a lot of things with me. And then Jennifer over there is another RT. She is circulating today. And then we've got several people in the back. Can you just zoom over there? Just show, we've got a bunch of people in the back. Our CNO and research coordinators. Dr. Bilal Saeed is back there. He's one of our partner cardiologists. Luke, our cath lab director, is there. So our compliance people, our ID protection people, Jennifer, all of them are there. So this takes a lot of time and effort to do this. Okay, so instead of just having the access all together, I wanted to do it from start to finish. Normally this procedure is not that long. So I can show you some of the stuff that we would not show for a long case, like a mitral clip or a TAVR and stuff. So all our rooms have embedded wireless ultrasound. So this is a Siemens ultrasound where we have it right there. And Heather, can you go over there and start pointing what we're looking at? So you all remember that artery, or you're going to have to push it back and turn it so Jay can show it. You got it? Okay. So remember that the vein is on the medial side, right? We all know that, obviously. This is interventional cardiology. And then go ahead, show the artery. This is the artery right here. When I push on it, it doesn't collapse. This is the vein here. When I push on it, it collapses easily. And, you know, I've probably done 15, 20,000 arteriotomies without ultrasound and about 10,000 with. And I would tell you it does make a huge difference. And at least in my hands, it's a much quicker, and all of our partners' hands, much quicker, simpler thing to do. So you can see that I'm seeing where I'm going in. And sometimes, I'll take those. So I've got the color, I'm going to turn the color off and actually show you where it's going in. Right here, you can see I'm in it. I don't have any blood back, but I know I'm kind of in it. In the artery, it's much easier. So the blood comes in. So we're through. Okay, go ahead. We were going to have Dr. Vajahat Lodi from Foundation Hospital and Dr. Samula. We were supposed to get here in Oklahoma last night. They missed their flight in Miami, so they won't get here till noon today. You'll see them tomorrow. Okay, so what I want to show you is a new, some of you have used this, but some of you in Pakistan may not have this. We're going to use the Baylis transseptal system. So this is the latest thing that we have. This is called a VersaCross wire. So you see it's like a pigtail, like a safari wire, for example. Can you see it okay? Okay. And this shortens our steps quite a bit. And let's just do it live. So I have that ultrasound over there. I'm going to switch to TE. Can you switch to TE? Can you guys see me okay, hear me okay?
Yeah, we can see you and hear you as well.
Okay. So there's that pigtail wire that I'm taking up there. And if you look at the TE, you can see that line. Obviously, you remember the SVC on the right side, IVC on the left side. This is a bicaval view, left atrium on the top. You can see the intraatrial septum. It has a little bit of lipomatous hypertrophy. I think this is kind of the patients where the VersaCross or Baylis transseptal system works out better, or those septums which are very, very mobile, atrial septal aneurysms. Because when you take a small needle and you're trying to push it through, it can almost go to the lateral wall of the atrium. And so,
He's got the thread in. Yeah. Not yet.
Okay, can you show that over there?
Do you
You have to
change
show and
every-
stop and talk.
do you change, Dr.
for
TahirKheli, your
ev-
puncture site to make it coaxial with the left atrial appendage, or do you always have a fixed puncture site?
He's going to have to speak up louder. Hold that. I'm sorry, is it Osman or Ali Reza? Who is there?
Yes, it's Ali Raza.
Ali, you'll have to speak a little louder, and I'll turn it up. Remember,
so-
I'm an old hag, I've got bad ears.
So if you
So-
could kindly just tell us about the selection of the puncture site and the septum there.
Yes, that's what I'm going to go over there. So, Ali, can you see that? Okay. So for every patient, we will have the TE and CTA measurements that we've done over there. I will write them down and we will hang them. And then that's the CT rendition that's on there. So the important part is to know what type it is and how you're going to access.
We have
So,
lost the video,
this
Dr. TahirKheli, we have
this one
lost the
obviously,
video.
this one obviously you remember is chicken wing. So there is a lobe that is going anteriorly. So we are going to go really inferior. Once we go inferior, we'll be able to access the left atrial appendage much easier. So keep on that.
Can you please switch on your video because we have lost you? So.
Give us a second, we're working on it.
Sure.
Let me know when you can see me, so then I'll do the transeptal.
Sure. Yeah, we can see you now.
Okay. So all of you obviously do it differently, and you guys, I tell my colleagues here in US that our Pakistani colleagues are so much better in transeptal. You do it all day long. Here, you have 10 interventional cardiologists, and maybe one might know how to do a transeptal because we don't have as much mitral stenosis. Let me just get that up. Okay. All right. So, Dr. Lau, let's go to the bicaval view. So my first thing is I want to be inferior. So I'm going to take this, turn this. And so this right here, I didn't show you. Can you show this here? This is actually, there's no needle here. This is just the dilator and a catheter and a sheath. So I'm going to turn towards the spine, obviously. And you can see right up there, are you showing the
Denting.
Okay. And then I pull this down slowly. Again, my idea is to go inferior and a little bit posterior. So, Dr. Lau, you're going to have to push your, yeah, there you go. Thank you. So watch, I'm looking at the floor where his TE is. That tells me if it's too high, he's not going to catch me very well. Okay. So now see if you can turn it on to, actually, Dr. Ali, you want to do this real quick?
Yeah, we can see you actually, so yeah.
Okay, so now we're on the aorta, right? And so you can see we're right there, and you can see me pointing right there. So I'm really pointed anteriorly. So from here, I will go a little posterior. You watch this knuckle, or we call it nipple, for example. Heather, you got it?
Yeah.
Dr. Lau does it all the time. Okay, so you can see where my knuckle, show that, can you point out? Right up there,
Yeah,
right there. So that's where I am. And can you explain that for me? You're good enough, this is pretty posterior. All right, so you can see it's pretty inferior on the right side, right here, and it's pretty posterior on your left side because you've got aorta is always anterior, all right? So from here, it's very, very neat. I'm going to go here, Jennifer Byrne. I'm in. And this is not a sharp needle. I've got a pigtail wire in there. I'm going to push in and ready for heparin, full heparin. Okay, out.
So your sheaths, watch your sheaths, please.
So you can see my sheath has gone almost into the pulmonary vein there. Ready? So now come down here. So I'm going to put a pigtail in here. So when we start going at the appendage, I go to ariocaudal. That's a little better view. You can do ariocranial, ariocaudal, and ariocaudal obviously that correlates with 135-degree angle on the TE. Okay, Ali. So we're going to try to do counterclockwise and see if he can get.
Pigtail going into the vein.
Okay, so you see that? And I'm going to go a little further up there.
Vein.
So it's going to come down here. Okay. So just make sure you show him the top part, and as I turn.
So that's your pigtail.
Open.
It's almost at the os.
Almost at the os, you can see. So again, we said it was a chicken wing, which is a little acute angle. So the appendage is the most anterior portion, and all I'm trying to do at this point, unsuccessfully obviously, is to get into the most anterior portion. I'm pretty close. Can you show me a little bit?
So it's right. It turns around and then right comes in front of the os, but not going inside. See that? It's right there.
Right there. And then the great part in this, of course, is
he's struggling with deploying it.
Oh, yes.
okay. So I'm going to try to go just with the guide in there and see if we can manipulate it a little bit better, boss. Can you see me?
So
Right there. Very good.
Maybe you should. Is your guide too anterior, maybe?
Huh?
Is your guide too anterior?
It is. Huh? Yeah, I have. Turn around that. Go to the appendage view.
So that's why I think that's what you were emphasizing, that the puncture site is important in LA appendage, because you have to be very.
Yeah, and we tried to go really inferior and posterior.
Yes.
Just because of this, because this is an anterior thing. And of course, we're doing a live case, so it's going to take us a little while, right? So good to have a tough case to do it.
You can take your time.
Okay.
It's
Pretty close.
hitting the limbus, Q-tip, right there,
Okay.
and going into the vein.
So you can see it's. Okay, give me a multi-purpose boss or just a GR4 real quick. GR4.
Should we stick again?
No, I think we have a good stick. Give me flash. Connect the flash. Or wire. Push the wire. Yeah, push the wire and then. Got it. Okay, show me the appendage again. Okay, I should be there. No.
It's in the vein.
Huh?
It's going in the vein.
Yeah.
Yeah.
Yeah, you're all the way.
What about now? Okay,
Vein.
no, it's still the vein.
It's
So on my view, I'm almost there.
Yeah, but looks on the, Echo, it looks in the vein, is it at the top? Or?
Yeah, you can see it there.
right.
We're ready for an HCT when I'm getting me.
It's getting hot.
Have you ever changed your puncture site in order to get into it, or you
Yeah, so I have. We might have to change the site. We may have to go a little bit, not as far inferior and not as marked posterior. I think I might have
Yeah,
just gone
I
too
think that-
posterior, so I'm having to turn way anterior to get into that. So we might have to do that. Just give me
Not
one
yet.
second.
You're going to change the angle and go from the posterior now. Not yet. Not yet. Yes, you change the angle and go from the posterior.
Would an Agilis catheter go through your
Okay,
sheath?
let's try again.
I've seen him done in a video.
Naeem, if you have an Agilis catheter, if it'll go through your sheath, you would change the angle and direct it towards the appendage.
I think Abdul Hakim has got an idea name that if you use the Agilis catheter, I think he was talking about that.
Show me for 1 second. Can you give me a multi-purpose real quick? Yeah, that view. Turn around. Dr. Lau, show me the appendage. Before I do another one, I just want to give one more try with the ACT coming up, guys. Here we go. Okay.
Waleed, while they're doing this,
Okay.
I had a question which we discussed before as well, that the measurement for LA appendage in AF patients, and especially sometimes when they are in sinus rhythm, they have to be different. Is that correct?
Yeah, it especially gets very tricky when the patient is in a paroxysm of atrial fibrillation.
So you have to switch on the mic, Osman. Yeah.
Okay, we're going to go try another one, a little more inferior. Give me that. Flush.
Can you hear me?
So I'm going to come out. We're going to do a
tricky when it is
repeat
paroxysmal
puncture.
atrial fibrillation. Because if you have
Put
done
the
the
J wire
measurements in
through that.
AF and then you are doing the implant in a sinus rhythm,
So the last 100 I've done, for example, I have not had to
Yeah. So Waleed, yes, you were telling
cross.
us that you have to talk a bit louder. I think.
But it's always good to show the more difficult case. So we come back. I'm going to do another one. Give us a chance to push the wire through. Push the wire through. Okay, there we go. Be ready to burn. I'm going to go back to
I think they're
LAO.
changing the position now of the puncture, because I think they've been little bit more posterior, isn't it? In it, so.
yes.
Okay. All right, so let's try that again. Heather, can you come? Or Dr. Lau, are you there? Oh, good. Okay, so we're going to let me come down a little more inferior here on this view. So I'm happy with this inferior. Just give me a little explain and show me where I am on from the aorta. Or maybe just go over to the aorta. That looks good, huh? Okay, we're going to try that again. Burn. We're through. Let's try this again.
So other than changing the puncture site, what else you can do to get into the LA appendage? Anyone from the panelists, please?
Yes.
So I didn't hear you very well,
Sir,
Bashir, but I think
can you hear
what
me?
happened is that
Can you
in
hear
my
me?
hurry, I ended up being more superior than I wanted to be. So I really need to be more inferior, and this time I made sure I'm inferior. So I think we should be able to get in easier.
I think we were getting our panelist opinion as well, so just, yes.
Dr. Naeem, thank you so much for precisely demonstrating about the importance of
Can you speak louder?
Speak louder, Waleed.
the puncture location. This is a very good demonstration, and I'm sure you are really enjoying it at the moment. But apart from that is the pulmonary ridge thickness that is sometimes giving him a challenge in this case as well in terms of steerability towards the left atrial appendage. There are a couple of plan B, plan C here. The plan B is, as shared by Dr. Hakim, is we can use the edgeless catheter to steer it towards the left atrial appendage. The plan C is sometimes the simple thing works very nicely. You take a GR4 or a multipurpose catheter and take a soft wire and make your way to the left atrial appendage.
Yeah, I think the biggest challenge in this
That's what we had. We had JR4, and then we tried multi-purpose. They both didn't work. So
No, we're suggesting you use a agility. You can change the angles on it. Then it may add an extra step to your procedure, but it'll get you right in the os of the appendage. So
yeah,
the issue
that would be
here
the next
really is
step.
the
But I
lipomatous
think
hypertrophy of the
probably
septum.
before then, let me just try to get in there here.
Yeah, I think Ijal is, yes, this character of the leukemia might help them, but I think.
The problem is if you look at the TE, there is lipomatous hypertrophy of the septum and the fossa ovalis is really, really short. So because of the hypertrophy of the septum, it's precluding the sheath from really pointing downwards. It keeps going up towards the left upper pulmonary vein, and that is really the challenge. So I think we really need is a deflectable catheter that could overcome that resistance right at the mouth, at the door, which is the septum itself.
Okay, give me the J side of the wire.
And for hydration, to keep it
new
the
J wire?
volume
Just a new J
up
wire?
of this procedure, because for the measurements, obviously the hydration status effect. How much fluids do you think we should give them? Is there any measurement for it?
We gave about a liter. Overnight. Generally like to give about a liter before we bring him in here, as long as obviously the LV function is okay.
I think that's a very good point, Ali, because the LV is hyperdynamic. It's pretty much collapsing. I mean, if you look at the LV, it's hypercontractile, and part of it is the patient's in AFib, but maybe some more volume could open up the appendage better. But I don't think that's really the issue here. The issue is the lipomatous hypertrophy of the septum. He's punctured it twice. The septal puncture is perfect. It's just that hypertrophied septum, which is preventing it from going downwards and anterior towards the left atrial appendage.
Yeah, yeah.
So what wires would you use if you were to use a multipurpose or JR? What wire would you use in the appendage to try to get you closer to it?
Well, I personally would just, at this point, use an Agilis catheter because, you know, time in the left atrium, next thing, you're going to form a clot on it, and you'll have to abandon
See if you can get me an Agilis catheter, guys.
Probably we have convinced you to use that, too much.
Yeah,
so we've done several hundred now, so I've never used an Agilis.
014 wire, 035.
So to direct yourself, you can take the angiography.
You have to talk louder, Waleed. We can't hear you.
035 wire.
So the question was, what will be like, wire will we be
Derek,
using?
you have any thoughts?
And where do you keep your ACTs for these procedures? And
300 and above. 300 and above, always. Okay, give me that picture again.
I remember someone had to remind you that it should be there, and there's a responsibility is to tell you to give heparin as soon as you cross. Is that correct? That's what we had to do.
Yes, that's why our anesthesiologists are so great. So that was given as soon as we did the transeptal.
So we were talking about the measurements as well, that AF related. I'm probably asking this question again. AF and sinus rhythm measurements. If the patient comes in sinus rhythm or in AF before and sinus rhythm afterwards, what would you do?
Can I answer that? If a patient's in normal sinus, you should not be closing the appendage, period.
No, paroxysmal AF.
Right.
Yeah, I think that's a partially valid comment in a way that there is a group of patients with a paroxysmal atrial fibrillation. That's where you come across with this, and that's why you have to combine two modalities then. Because you are, at one point you are dealing with a quite circular orifice of the left atrial appendage, but when the patient is in AF, then you are dealing with a kind of an oblique or an elliptical orifice, and in case of amulet, of the landing zone as well. So both of them have to be dealt with differently, but I will talk about the elliptical kind of orifice. In that case, you should go for the major axis and undersize it from the major axis, because you don't want to have a peri-device leak, PDL, which is unfortunately then you are kind of making your patient more prone towards the DRT, device-related thrombosis, and a long-term anticoagulation.
Can you go through the thick part of the septum through RF ablation type of something like radio frequency ablation, or the thick part of the septum?
No, this is radio frequency ablation.
So I just want to ask Dr. TahirKheli, can we do another talk while you guys are doing this, or do you guys want us to stay with you?
We're about 10 minutes away. As soon as I get in, we'll be done.
Okay. It wasn't from me, it was from Dr. Bashir and Eve. I can't take that risk.
So I think while we are discussing left radial appendage, one thing we could really discuss is what is the scope of this therapy in the Pakistani population. I will tell you, I've been very excited about this, and I've asked pretty much everyone in our healthcare network, including my EP colleagues, to send me a patient who would qualify for left radial appendage closure. And over the past 8 months, I've been unable to find one patient, not one patient.
Same with us. We did clinics in RIC to find patients.
Life expectancy is 66 years, okay?
Show me the aorta.
Median life expectancy of our population is 66 years. Where are we going to find patients? The majority, over 90% of our AFib is rheumatic valve related. I don't think we
I think it will be only for the
AF like we do in the
Yeah, so I think that's an important point, that a lot of our AFib is rheumatic, but also a lot of the referrals, even in the West, come from neurology and GI and the medicine services, and not necessarily from pure cardiology. And that may be a reason. I think it's important to get all of our neurology and GI colleagues on board
before I go there.
To screen for these and you know, help with patient selection.
I mean, I'll tell you, Usman bhai, I had the same concept. Now at our institution, we've done well over 110 acute stroke interventions. So you can imagine, to get to 110, we've probably screened well over 1,000 patients who would qualify for thrombectomy. And I will tell you, less than 5% of these were AFib related. Less than 5%.
My question is there,
Our
Abdul
strokes are
Hakim.
happening in younger people, in their 40s and 50s. They're not the 70 or the 80-year-old. Yes, do they exist? Sure.
But it is for the bleeding patients actually, because you screen these patients, but you don't follow up the bleeders who were there. And that's our question from Dr. Asim Javed was as well, that these patients who have a bleed related to warfarin, that's the target. Probably not probably the stroke ones, and that's what we were trying to hunt for. And what happens that when they come to the stroke unit like RIC or NICVD, you guys exclude those ones. You guys send them back. And they're never tracked back, actually. The bleeders.
Follow up.
No,
So
you are right, Ali, but the issue is, and I've looked at this very closely because I am invested in trying to find patients that we could close. The issue is our bleeders and our patients who are on Coumadin are patients who have mechanical valves. Who in this day and age would put someone with AFib, a high CHA2 on warfarin? Almost nobody, unless somebody failed DOAC therapy and had a stroke on it. So yes, it does constitute, and I'm sure our stroke experts can opine about that, but what I'm trying to say is we have to really find out what proportion of patients would actually, and I think for this we'll have to do a multi-center study and see really, if you see, Farooq showed a very nice cost-effective analysis chart. The cost comes out about $25,000 to $30,000. And it is not going to be until 5 years when it becomes cost-effective in the US. Okay. So I think those are very important consideration for us to launch a left atrial appendage occlusion program.
Okay. Yaver, you looked at AFib, and what they found was that the first presentation of AFib in a much younger population was stroke. And so there's certainly a young patient population with AFib there that, despite a low charge VASC, tends to have earlier strokes. And I think so there is a patient population that could benefit from the technology, but it's about a multidisciplinary approach and the right patient selection.
Yeah, one of the things I suggested to my neuro colleagues was we see a lot of these ischemic strokes which develop this hemorrhagic thing in the middle, and then there's always this debate on when do you start them on warfarin and stuff. Maybe we can actively target some of those, especially the ones with a massive stroke and have significant bleed inside them. Maybe these are the ones we can have in our population, because as you said, the average age is pretty young. So we are not going to get those 80 and 90-year-olds.
It's severe angle into it, boss. So we're in it. I'm just going to have to maintain it. It's really at an acute angle.
I still think the
really, really bad acute angle.
is the way forward, because there's a lot of awareness to create, and even among our doctors community and neurologists.
And Abdul Hakim, Boston is sitting here, and they're listening to what you're saying.
I'm still there.
So.
Whatever I'm saying is for their ears.
But I think also having regional centers where you can have a public-private partnership, which would mitigate some of the costs and also help with funneling patients in the right direction.
Okay, we're inside, guys, finally.
So they are in now, so that's good.
I think they are back on track now.
Yeah, it's a very acute angle, so it'll be interesting to see how it deploys. Very, very acute angle.
That's why you should have started earlier, Dr. TahirKheli. See, it's always in the live conference.
How did you get there, Dr. TahirKheli? Right? Can you walk us through how you finally managed to succeed?
So what did you do to get in there, Dr. TahirKheli? That's the question. So device selection, what do you guys think about Watchman and the emulator? What's the question?
A few years ago, we did trial for both Watchman and Plaster. So we stopped everything for 3 months and did Watchman, and then we did Emulate for 3 months. And everybody said we wanted to go with Watchman. The reason is Emulate is new, we're starting.
Device to use, very user-friendly.
The deployment criteria, how we're doing it, was not completely set up at that point. So this is the angiogram now. We're going to run through this hopefully pretty quickly and not have any more difficulties. But
method is just giving a bit more.
You'll see Derek kind of measure this.
So can you just focus on the measurements for us, please, Dr. TahirKheli? I think you're just going to measure it now.
You want to take this? Okay. There you are. So, yeah, no, I'll get up there. So just, We're good. Ready? Do one more. See that chicken wing going up anteriorly? So that's why we had to go really inferior to kind of get that.
You know, this is the most annoying part when they draw on your screens.
And then you don't have to move, you don't move the table and all that.
So what we're doing is that sheet is and then, so let's go over our TE. So at 0 degree, we had 21. At 45, we had 22. At 90, we had 1.72. At 35, we had 2.12. And then on CTA, we had what? Okay, so this is a short one. So you want to do 24 or 27? Okay, so we'll just have
So India and US has got bad receptions as well. It's not only in Pakistan. I'm glad to see that actually today. Because the Wi-Fi keeps on dropping in US and India both. So.
Okay, come over here. So let me show you the device. We actually, Dr. Cody Jewell, who's my electrophysiologist and a very close friend, here he walked into. He thought I was having difficulty to come help me also.
Almost.
But Dr. Jewell actually does it
The
more
big
than
part
me,
is
so-
done. We finally got it deployed.
So, Dr. Jewell, you want to talk about
He was
chicken
letting
wing?
Ali run the thing, and then he was directing and all that. The basic.
I think if
here.
video quality is not that good, Dr. Tahir.
Yeah, you can give your microphone. Okay. You can go closer. Okay.
In this case, you have kind of a anterior directed chicken wing so that the appendage comes off and makes an abrupt angle. So what you want to do here, catheter this way, is rotate it clockwise and it'll rotate up and set into this angle. And to start your deployment at around 12 o'clock in this picture, and then drag it with counterclockwise as you rotate down, it'll drop into place there. Those are tough, small appendage. Doesn't have a lot of depth to it, so it's going to be a little bit of a challenge.
Okay. Jay, show me that. Cody, thanks. Okay, so we're just basically, this is, Cody does it differently and I do a little differently. We have this access to this, and all I was trying to do is give it up any air through that. Keep going.
I'm going to smash this at the end of this session, I think.
Can you guys reconnect, Dr. Tahir? Because we are losing you guys a lot.
He'll run two EP labs and run from one to the other. Our in and out time, obviously this is not a good case to show that, is about 25 to 30 minutes. From start to finish, it's about 30 minutes. Anything? Okay, all right. We're going to go put that in. Hopefully it will not mess us up. Yeah. Yeah, do you want to go up into the chicken wing or not?
Well, I think for right now.
Okay, let's do that. Okay. Yeah, that's the concern.
Yeah, the device is going to naturally.
Yeah, it is going to. Okay, so if you would, Dr. Lau, expire and hold your breath. No, pull back, And I'm going to do a little clockwise here. And now I'm going to start releasing, and we'll see how that works. So this is the ball that's out. So once the ball is out, I can push it and be aware that it's not going to hurt the left atrial appendage. And on the T, you can see on the right side, it's coming out. Sorry? Yeah, it's kind of going. Yeah. You can breathe, boss. Yeah, it got a little turn, so we'll recapture it. So you're seeing all the things that we can happen in there. So what I'm going to do now is I'm going to pull this back. Hey, guys, can you go to 15 frames so they can see it? I try to keep it at 7.5 frames, so I'm not using too much. Okay. Sorry? I'm going to go up a little bit. So we're going to go up a little more higher. So, sorry?
So what size did you choose, Dr. TahirKheli? We lost you guys there. So what size did you guys choose?
We chose a 27.
27.
You like it there, Derek, or not?
So again, for sizing these days, is it still a pre-procedure TE or CT is good enough to, what are you using these days?
I think what I personally prefer is the TEE, and the reason being is you do have the same modality during your procedure that you can use, so you have got comparable with comparable. While on the other hand, CT measurements can be slightly different while the patient CT is done.
Yeah, and I think as we release it, it'll
on the
get a little
table
bit
during
better.
the procedure. But if there is any concerns during the TEE or you are not getting good measurements, then we go for a CT. So routinely, we don't do TEE and CTs. CTs is only on those specific cases where we have concerns on the basis of TEE.
And have you used ICE for this or not?
Yes, we did. We did use ICE intracardiac echocardiography in certain cases as well.
Yeah.
And on the last CSI Frankfurt, we did a live case.
So we're now up into the
using
chicken
the
wing.
ICE for amulet left atrial appendage closure
So
as well.
So what I'm doing is I'm all the way as far
you can avoid general anesthesia
anterior
that
I
way.
can
So
go.
if you do a pre-procedure CT
And we're going
and
to try to.
use ICE, there are cases reported where they use TE but very briefly. So pre-procedure CT sizing and a brief TE, and they do the rest on fluoro.
Absolutely, I think it just depends on looking into what is available and what can be best for their practice. So if CT is easily available and you want to minimize the timing for the sedation and anesthesia, then absolutely that's the best approach. For the ICE, where I got trained, they were too much into ICE to minimize the support on the anesthetic team. So even the PFO closure and ASTs will go under the ICE as well.
Yeah.
Once we back it, yeah.
Yeah, let it settle down, and then I'll tug it a little bit. Okay, this is about as difficult as a case you can get, but I think we've got a good seal there. Okay, I like this. Cody, a lot better, huh?
Oh, yeah, see here.
Okay, so show the ultrasound, and Cody, you want to go in and show. Go ahead. Who has the microphone? Okay. All right, Cody, show that. So, no, don't turn it away. He's taking the video.
Okay, so here's the Watchman device sitting right here in your.
You guys do the measurement, Derek? You do the measurements? Hey, would you get the microphone closer to you, Cody?
Okay, sorry. So the left atrial appendage kind of starting here. You have good apposition. Device looks great, sitting right there. There's a little anchor to it. And they'll take a measurement across the shoulders of it. It looks compressed.
So this is a 27 millimeter. I want it to be about 20.
Yeah, looks good.
Yeah, 22% compressed is about where you're at, which is what it looks like. It looks like a good 20% compressed device. They get very, as you lose compression, they become more like a cube. And so with a little bit of length to it, you can see that it's compressed, like I said, 21, 22%, somewhere in that neighborhood. And then here you have a little bit of a shoulder on
That's
your 135 view.
135, which is okay.
Which is great, yeah. I mean, a little shoulder is fine.
And as you go to 90, you won't see it as much.
The fabric of the device covers about 2/3 of the device. So the fabric's going to cover down into this position right in here. And so we have good.
Monica, put some color flow so we can see if there is any color going down into the appendage. Ali Raza?
Yes. I'm still here. You guys enjoying your coffee?
You can see what it looks like. You ready? Inject a little bit. Okay, good. All right. Inject. And you can see that nothing is going into the appendage.
Yeah, that looks good.
And then we do what's called a tug test. So I'm going to just pull on it and say, oh, is it moving or not? And then you can look over there on the...
and can you take us through the
I'm
checks
pulling
as
it,
well?
It's not moving. So I'm going to start releasing it. Okay, and then you're on the fluoro, Jay? Okay. So the other thing I want to show you, we showed you the ultrasound. This is another thing. You guys do a lot of venous procedures with mitral balloon valvoplasty. I would recommend doing this. This is a Z-stitch. Show over here. And I think some of you are already doing this, but me and Cody have a special iteration that we'll show you today. So just a simple straight thing.
Yes, Dr. TahirKheli, thank you so much for showing us this case, and thanks a lot
just one second. Yeah, just 1 second. See this first.
Oh, okay, yes,
We're
yes.
done.
I've learned this from the video which you had shared as well on the WhatsApp, so I had learned this technique from you with a 3-way tap there.
So at this point, a lot of people do the Z-stitch, and this is a Z-stitch. The thing that we do is we put this in, and that way when they go upstairs, they can loosen it up or tighten up if they want to. The trick is don't go more than 45, otherwise the thread will done. We're done. Sorry it took us a longer time. And oh, there's a 3D that Dr. Lau showed right there. Beautiful. See that, how it's completely occluding the appendage?
Yeah.
Thank you very much. Sorry it was a little more difficult, but that was also the fun part. This has been probably one of the most difficult ones I've done in the last.
Thank you so much. Thank you so much from here, from Pakistan, and hopefully, inshallah, we'll see you soon in future.
Yeah, we'll see you tomorrow for that coronary case. Thank you.
Yes, inshallah. Okay, thanks. So we have got one more speaker, I think, left. So we've got Dr. Charanjit Rehal, and it's a paravalvular mitral regurgitation, I think, which they're going to present. I think that's probably the last talk of our today. So please hang on with us a bit more, and then we will have any questions after that if you guys want. Thank you.
Hello, my name is Dr. Chet Rehal from the Mayo Clinic in Rochester, Minnesota. My pleasure this afternoon to talk about mitral paravalvular leak closure, an important and persistent problem that all of us who deal with valvular heart disease see. There are many risk factors for paravalvular leak, including the well-known annular calcification, tissue friability, prior endocarditis, inflammation, initiation of corticosteroid therapy, and even implantation technique, since interrupted sutures have been shown to be associated with less PVL than continuous sutures. There are many anatomies and sizes and configurations of paravalvular leak, including some that are fairly short and discrete and favorable for percutaneous closure versus larger longitudinal valve dehiscences that are not so favorable for percutaneous closure. So let's review how this procedure is performed. The first and most important thing is to have excellent real-time imaging. This is a 69-year-old man who was 6 years following mitral valve repair with a ring, and as you can see, there's clear paravalvular leak outside the sewing ring. What we have now done is we have advanced a catheter through the defect from the left atrium into the left ventricle, and we have extruded the distal retention disc of our plug. We then pull it back, and we lock it into position by deploying the atrial retention disc. And this is what it looks like with real-time three-dimensional imaging. The advent of real-time 3D transesophageal has been an excellent advance and a real boon to our practice, and it's an absolute must now to perform this procedure safely and effectively. We can treat many defects, including multiple defects. This was a patient who presented with frank pulmonary edema, had 3 large defects, which we closed, and following closure, the pulmonary edema improved and the patient left hospital within a week. It's really quite remarkable. A very frequent question I get asked is how to size these plugs. The first thing I would say is don't spend too much time measuring the exact dimensions and width and length of the leak. What's really important is to identify this rectangle that covers the entire area of the leak. So for example, this may be a 12 by 8 millimeter rectangle, and the way we then treat it is to put in 2 small or medium-sized plugs rather than 1 big plug. This is the way to get the best result in as safe a manner as possible. Typically for mitrals, we would use 10 or 12 millimeter plugs, and the plugs that we use are these. The AVP family of plugs, particularly the AVP2, which is available in America. The AVP3 is not yet available, but is under investigation. Now, the thick braid devices, such as septal occluders, ductal occluders, and VSD occluders, can be used. However, the thick braid does predispose to hemolysis because of high velocity jets going through the devices. Now, how do we get in multiple plugs? Well, this is the simultaneous deployment technique. As you can see, we have placed 2 6-trench guiding catheters across the defect and are deploying 2 plugs simultaneously. We have to take extreme care and caution not to entrap, obstruct, or block the prosthetic leaflets. That's just an absolute must. Sequential deployment using an arteriovenous rail is a current technique that we use for most patients with large mitral and other paravalvular leaks. An arteriovenous rail is created by exteriorizing the wire. Then over top of this, we can put in a delivery system such as a coronary guider or a shuttle sheath or some other hydrophilic sheath, and then sequentially deliver 1, 2, or 3 plugs as needed. It's a very quick and efficient manner. We can even do paravalvular leak closure as an adjunctive procedure to other procedures such as mitral valve-in-valve implantation. So this is an example of where we put in a plug into a large mitral paravalvular leak, and then we placed a sapien valve into the pre-existing mitral bioprosthesis. And you can see how we pre-dilated the septum, then got the sapien in and treated the paravalvular leak with the plugs at the same sitting, a very efficient procedure. And here is the final result with the sapien actually pushing out the struts of the mosaic valve. Now, here's a novel or different way of closing a paravalvular leak, and this is after a self-expanding valve placed into the aortic position. You can see this calcification has induced a large volume of paravalvular leak. So rather than trying to plug it, the way we treated this is to place a balloon expandable valve at the base of the self-expanding aortic prosthesis. This then very effectively treated the paravalvular leak, and as you can see, it's vastly diminished. This is an example of where we had a patient with two different valves, a core valve in the aortic position and a sapien in the mitral position to treat mitral annular calcification, who then presented with severe leak of the intravalvular fibrosa. So we approached this in a standard transseptal manner and delivered plugs while being extremely careful not to traverse the cells of either the core valve or the sapien valve. That's extremely important when doing these complex procedures. And there we have it. So, what is our goal? Well, the goal is to achieve as small or as trivial a residual PVL as possible. This is a patient with a mitral bioprosthesis, and we've placed a plug into this leak with almost no leak. This patient will do very well, in particular, if they have a response of the left atrial pressure. This is a case example of where the left atrial V wave was 60 millimeters of mercury before plugging, and following the plugs, it went to less than 20 millimeters of mercury. So this patient will feel better immediately and have a very good improvement in their quality of life. So how are we doing nowadays? There is a significant learning curve to this procedure, but after performing hundreds of these procedures, we can now confidently say that we can offer this procedure with a 90% uncomplicated success rate to our patients. So to conclude, paravalvular leak is not very common, less than 5%, but still occurs. Endovascular closure is definitely feasible, but there is a significant learning curve. 3, residual regurgitation is the key determinant of outcomes. And 4, paravalvular leak closure improves symptoms, quality of life, hemolysis, and lowers the need for subsequent surgery. It's also associated with lower mortality. I did not have time to show you these data, but I also want to point out that we must be ready for the unexpected if we're going to do these procedures. This is an example where the plug embolized to the left ventricle, and we need to be ready to retrieve these plugs if this happens. So I thank you for your attention, and it was a pleasure to be with you again.
Thank you so much, Dr. Rahel. Thanks a lot for this presentation. I've got a question, Dr. Rahel, if you could hear me. Oh, it's a recorded one. Oh, okay. So that's not live. So thank you so much again. So that's our last presentation, I think. So let me ask you guys a question. When will you wait for a self-expanding valve to declare it a paravalvular leak? How long do you wait?
The question, what's the question?
So my question is that for evolute valves, paravalvular leak can be there after the procedure, and usually it improves. What's the time duration that you can think that that's the, okay, it's not going to improve from there? I've seen it 3 months and leads up to 3 months. So.
But I think on the table, you don't leave anything moderate, mild to moderate maybe. If you know the anatomy and you know, okay, there was nothing calcium chunk or something like that you have already decided that you're going to leave, I think anything more to you give about 10 minutes on the table for the valve to warm up and open up. But after that, I think if you are leaving more than moderate, definitely you are expecting the parallel leak to go down by at least 1 degree in 72 hours to about a week. But moderate or anything like that, I think you need to wait and maybe fix it on the table.
Sure, thank you. So any more comments or any questions, please?
For how long you recommend continuing the anticoagulation and antiplatelet therapy, especially after implanting this device?
So the original recommendations based on the trials was 6 weeks of anticoagulation and dual antiplatelet therapy, then dual antiplatelet therapy up to 6 months, then single antiplatelet therapy. Based on registry data, that's changed now that they're not mandating that you have to do anticoagulation. You can just do dual antiplatelet therapy. And it's kind of at the physician's discretion when they decide to switch to single antiplatelet agent.
And what if you get device-related thrombosis? Does it change the strategy?
It's like you have to look, as like in every other procedure, you have to look into factors. What was the outcome of the procedure? For example, if we are happy that the device was deployed nicely, the pulmonary ridge is not creating any problem, there was no any PDL, there is no any risk of DRT, then obviously you don't need to have an anticoagulation, and the risk of bleeding is high, then you don't need to have an anticoagulation and just continue dual antiplatelets for 6 months, and then only single antiplatelet afterward. But we do come across a situation where at the end of the procedure we say, it's not like 100% satisfied result. In that case, then we need to continue them on anticoagulation and do a TE after 3 months, ideally up to 12 weeks. And if there is no any PDL, no any DRT, then we can stop the anticoagulation.
Basically, just I want to point out one thing. This device was launched on the basis that in people who have got high risk of bleeding, because otherwise anticoagulants should be continued. People who had high risk of bleeding, this device was launched for them. But still you are giving them anticoagulants, as you pointed out, for 6 weeks. So they are still at risk of bleeding. And then you continue with aspirin at least for life, I think.
I think what they're talking about is the stroke patients, isn't it?
Yeah,
I think Sir is talking about the bleeding ones.
That's definitely a very valid point, because one of the main indication for left atrial appendage is the one who had a hemorrhagic stroke or any life-threatening bleeding. That's why we close the left atrial appendage. If we are happy with the results, then we do not want to continue anticoagulation. And we just want to have the antiplatelets because we want the endothelialization of the device. Otherwise, we will increase the risk of device-related thrombosis. So unfortunately, there is no any way out of giving a dual antiplatelets for 6 months. That is more promoting that we can then stop it after 6 months. If we interrupt this dual antiplatelets in the first 6 months, then unfortunately the device is not endothelized properly, and then the patient is at more risk of DRT. We are now moving quite a lot from giving, is rather discouraging giving any anticoagulation, especially coming towards the amulet device. If you are happy with it, we don't give any anticoagulation with the amulet, we just give dual antiplatelets.
So we've got one more question on their interaction panel, and that says, does the type of left atrial appendage alter the size assessment strategy, especially when it's a chicken wing type? I think I will pass it on to the panel, but tell me one other thing I will add on to this. Is there any specific chicken wing, windsock, this thing, or is it just the angles which you change the pictures?
So broadly 4 types of morphological classification. If you look into the literature, they have classified it in various different ways, but from the closure point of view, 4 different types. Broccoli, multi-lobed, chicken wing, and windsock. Chicken wing is, to me, it's the most challenging one to close. With the Watchman, you essentially kind of try to plug it as much as possible. With the amulet, what you try to do is more like a sandwich technique, where you try to go inside with your lobe, because the neck of the left atrial appendage is short in the chicken wing. So you can deploy the lobe, the disc of the device deeper, and then you can essentially chicken wing the device with the disc of the amulet. So yes, it is, and that's where you then consider whether I should go for a CT scan before the procedure as well or not.
So thank you so much. I think there's been question there, pre-BAV sizing in bicuspid. I don't believe in pre-BAV. You can close any bicuspid with any balloon, whichever you want, so don't do that. Okay, any more comments from anyone or any questions from anyone?
Just one point on this pre-BAV sizing in bicuspid. So see, sometimes, as you know, there are three phenotypes of bicuspid that have become fairly evident, right? You have really a box shape, you have a reverse flask, and you have a regular flask. So if somebody has a supraannulus or ICD that conforms to a 26 device, but then the annulus conforms to a 34, you're not going to put a 34 device. You're going to put a 26 device because that is where the valve is going to anchor. So in a case like this, a 26 device will have a waist of, what, 23? So you're going to pre-BAV with a 23, and you are going to do a aortic root shot for two reasons. Number one, you want to see which way the balloon shifts. Now, it's almost impossible for a raphe to break and the balloon to shift. But more importantly, you want to see that if you take a waist with a 23 balloon, are you going to get a lot of PVL or not? I mean, so you don't exactly size it, but it will push you more towards using a 26 instead of a 29.
Next time, Abdul Hakim, try a 20 balloon in it, and that will close it as well. This bicuspid always closes. So that's my take on it. But this is a very good point because you can see the coronaries and things, and that's also with it as well. So, okay, any more questions? I think we are all done and with it. I'm pretty sure, Usman, you have anything?
No, I think.
Okay. Thank you so much. I would like to thank the society a lot for giving us the opportunity for this structural session, and I would like closing comments from Sir Bashirin Saab or anything, if there is anything else to add on to this.
No, I think thank you very much, all of you, especially the moderators and the panelists for staying such a long time. I'm sure just sitting there for 4 hours would be difficult, but thanks a lot. There was some technical hitches, but hopefully this will get better by tomorrow. So thank you everyone for staying that long.